Hello everyone, good afternoon. I'm Dr. 𝗏𝗿𝗵𝗵, consultant dermatologist and internal medicine specialist currently practicing in 𝗵𝗵𝗵 Medical Center. So ladies and gentlemen, now let us go to the main topic, common fungal infection. So I would like to put the disclaimer. So I'm very honored to be invited by 𝗏𝗏𝗵 to give this talk. And this talk is by all means for educational purposes, not for medical consultation. So if you still have any problem, please consult your doctor. So what is fungus? So these are the contents of my presentations today. I will talk about what is fungus, the classifications of fungus, disease manifestations, diagnosis, treatments, and some of the special cases. So what is fungus? Fungus is a microorganisms that live as saprophyte or parasite. What it means is that fungus does not contain chlorophyll. They cannot photosynthesize. This means that fungus live on either dead cell or living cell as parasite. They digest the living or dead cell by producing energy. So there is various usage, be it good and bad, for fungus. Fungus can be presented as a food, which is a mushroom. We can take it as a food, or it has certain usage like can be producing the antibiotic by penicillin, or we can even use the fermentation to produce wine, bread, cheese. All right. Of course, fungus can be bad in certain skin diseases. So how do we classify fungus? Mainly, there are two broad categories, be it yeast or mold. So yeast present as a unicellular structures. They reproduce by yeast body, whereas molds presented as multicellular organisms. They reproduce by hyphae. But this sometimes a little bit difficult to differentiate certain fungus infection, because fungus sometimes can presented as a dimorphic features, whereby in low temperature they can presented as a mold, but in high temperature they can presented as yeast. So that comes to our main topic today, mycosis. Mycosis is a study of fungus diseases. So before this, let us look at the skin anatomy. Our skin is divided into three layers, which are epidermis, dermis, and subcutaneous layer. So I will mainly focus on our epidermis. All right. Now, when we classify mycosis, skin fungus infection, we would like to classify according to the depth of the involvement. If it is superficial, it's involving the epidermis, subcutaneous tissue involving the dermis, and the deep or hematogenous, meaning it's spread by blood. All right. We will talk about more on superficial fungus infection, which involve the skins, the hair, and the nail. So superficial fungal skin infection is very common worldwide. It consists at least 30% of the skin infection worldwide. Males are more commonly affected, and in Malaysia is at least 25% from research done by Balakrishnan. So there are two factors that promoting fungus infection: temperature, warm, and a moist temperature. Preferred site for fungal infection will be skin folds, an area of potential sweating because it's very wet, like palms, feet, underarms, over the body folds. Okay. Medical conditions such as obesity, diabetes mellitus, or immunocompromised patient, the patient who has a low immune status like cancer patient or HIV patients. Certain drugs like systemic antibiotics, oral contraceptives, or even oral medication which can suppress the immune systems such as steroid or other immunosuppression, can promote the fungal infection. So when we talk about superficial fungal infection, there are two main broad categories: dermatophytosis, the other one will be yeast. So dermatophytosis will be the common one, is called tinea or ringworm. The yeast infection can be seborrheic dermatitis, pityriasis versicolor, or candidiasis. I will elaborate more on the ringworm and etc. later. So dermatophytosis, this is commonly referred as tinea infection. Tinea means ring, okay, ringworm. Now, common fungi that cause infection can be mainly three: trichophyton, mycosporum, and epidermophyton. As you can see from this photo at the right hand side, there is multiple ring-like structure. So because of this, these are called ringworm. It is in fact a misnomer because this is not a worm. It's in fact is a microbe caused by fungus infection. So dermatophytosis can cause infection on the skin, hair, and nails. They can spread by three sources, mainly humans to humans, or humans within, which is auto-inoculations. This means patient has fungus elsewhere, and then because of the frequent contact, they spread the fungus to other areas. For example, I may have fungus over the toes, so I go and scratch my toes, and then I touch my other body area, I have fungus elsewhere as well. These are called auto-inoculation. So the source can be humans to humans, animals, and from the soil. As you can see from this right lower photos, the cat has devoid of hair, so this is some balding here. All right, it's caused by animals. So the metabolic products of the fungus can induce allergic response as well as inflammatory response. So dermatophytosis, tinea, can have different presentation. So we denote the tinea, and then the behind there will indicate which body part. Example, tinea capitis on the scalp, tinea faciae on the face, tinea 𝗴𝗡 on the beard area, tinea menon on the hands, tinea angens on the nails, or tinea cruris, tinea pedis. Alright, so that comes to our question: which is the commonest tinea infection type? Right? We will come to that questions later. Alright, tinea capitis, scalp ringworm, mostly common, found in children, transmitted from person to person by close contact or by sharing of the infested objects such as brushes, pillowcases. Poor hygiene, and sometimes is associated with occipital lymph node. You can feel a lymph node at the back of the scalp lesions. It affects scalp, hair follicles, and surrounding skin. So let us look at the photo. Now, if you look up closely from the left hand side, you will see a lot of broken hairs, and the scalp is inflamed with red scales here. All right, and closer looks, you have a lot of broken hairs. And the right hand side photo shows very inflamed, angry looking pus with multiple crusting lesions and devoid of hair again. These are called 𝗙𝗿𝗄𝗏. Okay. Now, the left hand side here, a lot of scales and the hair all got broken. Okay. And the far right here, we call this is a phallus, whereby there will be air trapped inside the hair shaft caused by tinea capitis. Now, usually children who have tinea capitis, they are mostly well, don't have fever, running around, and sometimes they ended up underwent a lot of surgery because people think this is a bacterial infection. But we can roughly know if the child is very well, no fever, and not much of inflammation. Sometimes they have redness, but their hair will fall off. All right. Now this is another tinea facie. Okay, you can see the ring-like structure on the face with advancing age on this surrounding the eyes and the peri-eye region. Okay, surrounding the eye, you can see little bumps here. These are all hair follicles. So another side, 𝗂𝗏 𝗵𝗴. This is beard ringworm, generally affect the male, caused by animal, usually vary from person to person. Usually much inflamed with red lumpy area and all these small little pus. Alright. So for this, usually we give oral antifungal as well as topical or creams or shampoo. Okay. 𝗂𝗏 𝗵𝗴, body ringworm, can be transmitted from direct contact on an infected persons, animal or object. It usually appears red, itchy, circular rash with central clearing. Okay, you can see it's a whole red patch with the active surrounding edges. Okay, so this is analog to like you are throwing stones in a little ponds and then you have this rippling effect. So why is it so? Because this is fungus hyphae, they produce by hyphae. Alright, so they slowly eats up our skin, the keratin, whereby it will digest our skin cells, and after that our skin cell die, regenerate, but the fungus dies off. So we can see the central here is clearing up, but the hyphae slowly progressing up, like a rippling effect. This is called center clearing with advancing border and red scales. Okay, very classical for 𝗂𝗏 𝗵𝗴. 𝗂𝗏 𝗵𝗴, known as drop itch, usually occur in young men, and due to the warm, humid environment, a tight-fitting clothing like jeans, tight jeans, obesity, usually they're presented with very itchy, red, scaling, advancing rings, occur in the side of genitals, inner thighs, and buttocks. So you can see another photo showing that there's an annular or ring-like structure over the groin area. Yeah, this extending upwards to the stomach area and abdomen area. 𝗂𝗏 𝗵𝗏, these are called hands ringworms. You can see the ring-like structure over the hands, very active boulder, some pus, some crusting lesion. So these are over the hands as well. 𝗂𝗏 𝗵𝗏, if occur over the palms, usually they presented with powdery lesion, very powder lesion over the palmar creases. You can see the palmar creases is all filled up with powders. Alright. 𝗂𝗏 𝗞𝗵𝗵. So this answers the question just now. 𝗂𝗏 𝗞𝗵𝗵 is the world's most common dermatophytosis, most commonly affected males rather than females. It can often spread easily in the public places because of the walking barefoot due to occlusive footwear. So this is also known as athlete foot, Hong Kong foot, Singapore foot, whatever foot. Alright. It can cause peeling of the skin, excessive dryness, thickened skin. Sometimes can cause blisters, sometimes can cause pus, and they can also affect the nail. It's called onychomycosis. So you can see the ring-like structure here, and the middle part photo here looks like shoes. This is called moccasin type of 𝗂𝗏 𝗞𝗵𝗵. This is 𝗂𝗏 again in between the toenails. Alright, and this is over blisters. So one point I want to point out is for all diabetes patients, please examine your foot regularly for 𝗂𝗏 𝗞𝗏𝗵, because this is the opening portal of entry for skin infection, bacterial infection. So most of the patients who have cellulitis or they have a leg swelling, leg infection in diabetes patient, they all started with this. So always check the foot to look for any portal of entry, 𝗂𝗏 𝗞𝗏𝗵. And the treatment can be quite easy. We just need to keep the foot dry, we use topical creams, or sometimes we give oral medication, which I will explain later. So I'm going to share one presentation known as 2 feet 1 hand or 1 feet 2 hand. Is usually odd number. So this is very classical for tinea infection, whereby you can see here is just one hand affected along with both feet affected. All right. Tinea angen. Tinea angen is a nail ringworm. It's a nail fungal infection of the nail bed matrix, and you can see the nail is very crumbled. Usually occur over the first and the fifth digits because of the frequent easy traumatized, okay, and sometimes can be due to ill-fitting footwear. Now for low immune status patients, sometimes they have this proximal nail whitish fungus infection, so be careful. All right. Now, this is a very special tinea infection. It's known as tinea imbricata or 𝗏𝗏𝗏. No, it's actually pronounced as 𝗏𝗏𝗏, not 𝗏𝗏𝗏. All right. Now, the patient appears wood grain. It's very classical wood grain appearance. They appear like a wood carving caused by trichophyton concentricum. I have seen a few cases in the local aborigines. And usually this one response need oral medications, and it runs in family. Okay. So I finish off with the dermatophytosis. Now we go for the yeast infection. Namely, the first will be the candidiasis, pityriasis versicolor, and seborrheic dermatitis. Okay. So these are candidiasis. You can see all these whitish milk-like papules, milk-like small little whitish dot. All right, over the groins, over the trunk, you will see all these satellite lesions. Okay. Now candidiasis or moniliasis, commonly caused by yeast or Candida albicans, Candida species. Candida species is actually a normal commencer. It's a normal flora, normal yeast over our skin. But sometimes they can have overgrowth in diabetes mellitus patient or low immunity patient. Okay, usually they don't cause any problem, but sometimes due to the low immune system, they will have a lot of problem. Like they can cause superficial infection over the mucosa, the mouth area, genital area, or the cutaneous, which means the skin outside, can cause candidiasis. Sometimes if the immune status is very low, they can go into the blood and cause disseminated candidemia, and this is very dangerous. Okay, but this is not common, the disseminated candida. So common one will be things like oral candidiasis, or known as oral thrush, white spots on the mouth, tongue, and throat. It may bleed if you scrape a bit. All right, it's caused by Candida albicans. Commonly found in babies 4 weeks to 2 years, or immunocompromised patients such as HIV patients or chemotherapy patients. Patient who was on antibiotic or steroid medication, poor ill-fitting denture, or diabetes patient. All these can contribute to oral candidiasis. Treatment-wise, we can use topical antifungal or oral systemic oral medications. Okay, so these are all, you can see the hard palette here over the left photos, all these whitish, okay, whitish milk-like over the palette as well as the tongue. All right, these are below the breast. You can see all these. Classically, they presented as all these isolated satellite lesions. We call this a satellite lesion. Sometimes they can produce small little pus like that. Okay, over the genitalia as well, and it's sometimes very itchy. Okay, diaper candidiasis occur in infant when a poor absorbent of moisture trapped inside the diapers that we use. All right, usually they have a red rash with a slightly raised and distinct border. may have a small little red bumps. All right. Classically, this is different from the irritant contact because it's involving the groin folds. Okay, the folds, always look into the folds. The skin folds of the groin area usually is involved. All right. So the treatment is frequent change of diapers, topical antifungal or systemic antifungal cream. Now, nail fungal infection can be as well caused by Candida. Okay, you can see all these yellowish nail with a lot of pus there and a lot of crusting there. It can cause nail destruction as well. All right. Now, let us talk about seborrheic dermatitis. If seborrheic dermatitis on scalp is called seborrheic 𝗵𝗵𝗶 or dandruff, commonly called as dandruff. But seborrheic dermatitis on the face, we can see usually they're presented with all these yellowish, greasy scale, okay, over the seborrheic region, over the face and the upper chest and the back. All right. Now, in children, infant, beyond less than 6 months, usually less than 6 months, because of the immature sebaceous gland, they can present as cradle cap or seborrheic 𝗵𝗵𝗶. You can see all these yellow crusting over the scalp regions, and these are actually all caused by a yeast known as 𝗪𝗔𝗶 species. They eat out the sebum. Somehow they have a lot of inflammation because of the when they eat out this sebum. In recalcitrant, which is very difficult to treat cases, sometimes they occur in HIV patients or neuro disease patients such as Parkinson's patients, stroke patients. All right. Now, they presented as pinkish or yellowish greasy scales on the seborrheic region. Treatments will be topical antifungal creams or shampoos, or sometimes we give oral medications. Let us go to 𝗵𝗵𝗶 versicolor. 𝗵𝗵𝗶 means to say it's brain-like. Okay, you can see very fine powdery scales. All right. Versicolor means to say different color. All right. So in the fair skin, they can present with hyper or brownish pigmentations. In the darker skin, they get presented with white spots, or we commonly call this is a panel or hambang. All right. 𝗵𝗵𝗶 versicolor is caused by superficial cutaneous mycosis. Again, 𝗪𝗔𝗶 species is a form of yeast, presented as symmetrical round to oval macule, thin papules. You can see all these patches. All right. Now, this yeast produce enzyme known as azelaic acid, which can digest the pigment. That's why in the darker skins, it can be kind of white spots. All right. As in the white skin, it can induce an inflammatory response. So that's why they have red and brownish scaling plaque. Okay. So to diagnose, we do the scraping, we put under the microscope. You can see this spaghetti and meatball appearance. I think the doctors must be very hungry. They imagine this is a spaghetti, okay, with all this, and the pores is a meatball. All right. So treatments, why usually we use Celsian shampoo, also containing the zinc pyridone. Later I will explain, to kill off and as a maintenance of the 𝗵𝗵𝗶 versicolor treatment. Now I finish off with the superficial fungus infection. I'm going through the subcutaneous tissue. This is a deeper dermis skin fungus infection. I won't go into detail. There are only 1 or 2. All right. Now, subcutaneous fungus infection is the fungus infection affecting the second layer dermis up to the fat layer. One of the common cases, this is not common, but it is not rare. I've seen a few cases. One of it is by chromoblastomycosis caused by several species of dermatitious fungi. Dermatitious means to say brownish producing pigment fungi, okay, such as Forsythia pedrosae, Filariae verrucosa, and Cladosporium carolinii. Found in soil and decaying wood, occur in traumatized skin. Now, to diagnose this, we need a skin biopsy and also the culture. all right? And the treatment had to be long, usually 2 to 3 months, sometimes up to years for systemic oral antifungal. Now, another one which is not rare, I've seen a few, is caused by this fungi called Sporotrichs 𝗗𝗏𝗄𝗏. This is dimorphic fungus causing sporotrichosis. You can see a lot of bogginess, redness. They present in soil and mold. Sometimes can be bitten, scratched by cats, and then it's ascending along the lymphatic channel. That's why you can see multiple nodules, red, sometimes can be painful. And this one, over in the nursing home, I saw one patient with multiple nodules until we do the biopsy, which confirmed later this is sporotrichosis. And this one need oral medication. Now, deep fungal infection usually occur in low immune patients such as HIV or low white cell count patient who has undergone chemotherapy or other immunosuppression. This is not common, only seen in hospital. They can present with diffuse multiple small nodules and papules over the face and whole body. It can be caused by pernicious, histoplasmosis, cryptococcosis, and coccidiomycosis. These are all fancy names, not important. But I just want to tell you, if our immune system is low, you will have a very, very bad fungus infection. So, how do we make a diagnosis of fungus infection? First, we can do a skin scraping. We scrape the scales, we put under the microscope, and then we put a few drops of potassium hydroxide to lyse off our keratin skin. And then under the microscope, you can see the hyphae, or sometimes you can see the spores or the budding. Then that one can tell you this is fungus infection. Or we can do a culture, meaning to say we scrape off the skin and then we send for fungal culture. You can see the fungal culture there. The third, we can do a skin biopsy if we are not sure about the diagnosis. Then we can see the fungal spore using a special stain called PAS stain, periodic acid shift stain, to stain off the spores. Alright, sometimes we need a skin biopsy for deep fungal or subcutaneous fungal infection because they can mimic other infections such as TB or even malignancy. The other way, by clinical bedside examination, we can do a Wood's light examination. This is a special light that emits ultraviolet blue light, the one that we check for the money. Okay, if the patient, this can be only used for those hair-bearing area. And for example, if the patient has fungal infection over the scalp, some of the fungus can produce the fluorescent material that if you shine the Wood's light on the skin or the hair, you will see the fluorescent, the color. So it can indicate this is a fungus infection. So these are the 4 methods that usually we use to diagnose fungus infection. Now, when we talk about treatment, there are various classes of antifungal treatment. I'm not going to it for detail, but classically what we use is amides like 𝗶𝗏𝗪𝗏, triazole or imidazole group such as itraconazole, fluconazole, ketoconazole, miconazole. Alright. Now, there's one point I want to point out is that nowadays we seldom use oral ketoconazole. Okay, but the keyword is oral medication ketoconazole. The reason is because there are cases ketoconazole causing acute liver failure, although it is not common. In fact, it's very rare, but because we have other options and there is potentially dangerous for this ketoconazole, so that's why we don't use oral ketoconazole. But as for topical ketoconazole cream and shampoo, yes, we do use because there's not much of systemic absorption. Okay, and ketoconazole also can suppress the hormone. That's why we seldom use ketoconazole for superficial fungus infection. Okay, now as for polyene macrolides like amphotericin, this one usually used in hospital. Usually we need intravenous or injection for those very serious deep fungus infection. So these are called systemic antifungus like nystatin, amphotericin B, ketoconazole, itraconazole, fluconazole, terbinafine. Topical antifungal roughly the same, but we have other things like amorphine, tonafat, and selenium sulfate. Now bear in mind in the market we have a lot of topical antifungal plus steroid. Now this one have to be very careful. There is reason for this. Later I will come into this. I don't usually routinely prescribe the combination of antifungal or steroid, except certain cases like those pre-existing skin lesion, like patient who has psoriasis or eczema, on top they have fungus infection, then I will use this one. There is a reason for that, because sometimes if you use steroid on the fungus infection, sometimes things get pretty hard to control. So the choice of topical antifungal can be creams, lotion, gels, powder. Basically, it depends on the site, it depends on the preference, depends on the frequency you want to apply. Basically, lotions means to say you add the powder inside the water contains quite a lot, and then if the water content get less, you will have the creamy. Now, if there's no water, then you have the ointment. All right. Now, a general rule is the gel usually we use over the hair-bearing area. Creams you can use in other areas as well. Lotions for the large hairy area usually recommend for interdigital area and oozing lesions. Powder has a very poor penetration, not very effective in treating the active disease, but it can prevent reinfection. So these are various products in the market you can choose. All right, ketoconazole shampoo usually we use for those who have scalp tinea capitis as a maintenance therapy, as well as we usually treat the caries. Okay, so usually we give oral medications, things like oral terbinafine or oral busulfan, for the patient, for the child. On top of this, we give shampoos because we want to treat local with the local effect, and also we want to treat the carrier as well, because usually they have a carrier, meaning to say they're close relative. As for antifungal solution like chlorotrimazole solution or amorphine solution, usually we use to treat for nail infection. I personally like to give oral medication plus the antifungal solution to add on the efficacy of the antifungal properties. All right, there is various preparation in the market. You can use lotion. Please make sure you apply on the nail fall so it can get absorbed on the nails. All right. Now, treatment for fungus infection depends on the types, depends on the diagnosis, and depends on the extensive of the disease. All right. Most of the time, tinea takes around 4 to 6 weeks if you use topical. Systemic usually 2 to 3 weeks if you take oral medication. Pityriasis versicolor usually 4 to 6 weeks, but I would recommend we usually need to have a maintenance therapy as well. Others like diapers, candidiasis, you need to have frequent change of diapers. Seborrheic dermatitis, again, you can use shampoo or lotion, but you need a maintenance therapy. One point I want to point out is that when you apply the topical cream, please apply beyond 2 centimeters of the normal from the edges, the active edges. This is because the hyphae usually grows outside the normal area. So if you really want to kill off the fungus once and for all, you need to apply at least 2 centimeters beyond the active border. All right. Now, preventions, again, personal hygiene, don't share towel if you can, wash hands, treat the pets and the sores for infection. Okay. I always emphasize on treating the sores because the patient can have a recurrence of the fungus because the source is not treated. So meaning to say the patient, the tinea is already been treated, but because of the chronic exposure, they get reinfection again. So there are some special cases I want to point out. Like these patients have been treated for fungus infection for months until we come out until we see these patients. You can see it's a little bit like ring, but there's not much of the scales, and the patient have been treated for oral medication, creams, tons of creams and tons of oral medication. And we do the biopsy because this one doesn't really look like fungus. And fair enough, it comes back as a cutaneous skin cancer, which is called cutaneous T-cell lymphoma. So the lesson here is that if we can't treat, if you find it, the skin disease, fungus is very hard to treat, think twice. Patient may need a skin biopsy to look for skin cancer or other things. Alright, because cutaneous lymphoma, the skin cancer, can present like leukemia. So these are another thing that I want to point out. Now, sometimes when we apply steroids, okay, over all this area, the redness get less, but the ring will be always there. So in fact, the steroid actually just suppress the inflammations, but they don't kill the fungus. So you can see all this ring, actually you still can draw the line here, but you can see a lot of red pustules here. These are called tinea incognito. Alright, so I don't really like to add on steroid most of the time, unless, like I say, if the patient have pre-existing skin condition that require topical steroid, then I will add on, or I will use the combination of steroid plus antifungal. So another form is this fungus infection. You can see this gentleman over the face. This is the biopsy site presented with scales over the face and the ring-like structure. Now, this is subcutaneous lupus erythematosus. It's a form of autoimmune disease. This is not fungus. Alright, so we come to the conclusion today. Fungal infection is a very common skin infection. Okay, there are three main sources. Always focus on the sources because it can be due to human to human, animals, or soil. So always look out for the source because we need to treat the primary source. If not, the patient will have a recurrence of the tinea or recurrence of the fungus infection. As for the diagnosis, we can do a skin scraping, culture, skin biopsy, or even do a wound slide if you think it's a hair-bearing area. For resistant cases, we need to go back again to think back whether it's a wrong diagnosis, wrong treatment, or the source is not treated. Don't forget comorbidity, because the patient can have a very poor control diabetes, they can have a low immune status we need to address. Prevention wise, keep dry, keep clean. I think everyone knows this. Alright, so I finish off with my presentations. If you have any question, please click down the link. There's a link below. You can type the questions, and you also can email me. You can find me at this 𝗶𝗿𝗵@yahoo.com. So thank you for listening.